To Dr. Sigasa, who has prepared a talk on a more broad view of management of BPE. Camera on. We're looking forward to
it. Good morning, everyone. Morning, Prof. Can you guys hear me? Thank you, Prof. So today I'm going to be talking about the BPE. My screen here. So morning, everyone. I'm Nkanyesi. So today I'm going to be talking about emerging interventions for BPE. So part of our history, in terms of prostate operation, the first prostatectomy was done in 1939 by a French urologist called Corvelard. At this time, the operation was deemed very dangerous, a lot of bleeding, a lot of comorbidities. Post that, a lot of modifications were done, including the development of the Millen's technique, which was described in 1945. Endoscopic procedures for the prostate were initially described in 1830s when a concealed knife was inserted into the urethra and a bladder neck incision was done. This also came with a lot of comorbidities. Then later on, a cystoscope was attached to this procedure, making it a bit more safe. More developments into endoscopic led to the development of a more modern day receptoscope, which was this first designed by two engineers in the 1930s. More techniques have been developed in the treatment of BPH, including laser treatment and other new novel techniques, which I'll be trying to cover today. So I'm going to be focusing on more surgical management, and we can describe surgical management. We can categorize it into invasive and non-invasive and minimal invasive, which is what I'll be focusing on today, the minimal invasive section. So the indications for surgical management for patients with BPH, I think we all know them: acute urinary retention, hematuria, which can lead to clot retention, bladder calculi and diverticuli, which are signs of end-stage bladder decompression, decompensation, recurrent UTIs, bilateral hydronephrosis, and renal dysfunction. So with the myriad of choices that you can choose from in terms of interventions, your choice can be made a bit easier by certain parameters, such as the prostate size, the patient's comorbidities or patient's level of function, patient's preferences, and the patient willing to accept side effects, and your expertise as a surgeon, and the availability of equipment to perform the certain operation you'd like. So the first intervention I wanted to chat about was laser. So this was just a slide describing a bit more about laser techniques. So the first laser technique I want to mostly focus on was HOLEP, which is a holmium laser enucleation of the prostate, first introduced in 1990. Holmium laser is the most advanced and most analyzed laser technique for the prostate. It basically uses holmium, yttrium, aluminium, garnet laser, which emits light wavelength at more than 2,000 nanometers, which is then transmitted via a flexible fiber. The wavelength is absorbed by water and water-rich tissues. And the laser produces a pulsed energy emission, and this high energy density leads to vaporization with a superficial coagulation zone and tissue death. Which patients can get a holmium laser? It's recommended for patients with a prostate of over 80 grams, patients with no contraindications to regional or general anesthetics, and patients who have no desire for fertility later on in life. The procedure itself is done under regional or general anesthetics. you need to have a 80 watts or 100 watts laser generator. The laser resectoscope is you insert the laser fiber within the resectoscope, a 550 micron laser fiber. You connect that to a 30-degree lens. We also use normal saline for the irrigation, and you also need a morcellator, which looks like this. And you have to have it ready and prepared. The basic principles is that the surgeon will follow the anatomical planes to enucleate the entire lobes of the prostate. The prostate lobes that are enucleated are then pushed into the bladder and then morcellated. So I just have a video here.
The first step in HOLAP is creation of bilateral bladder neck incisions at 5 and 7 o'clock. These incisions extend from the bladder neck to verumontamen and should be deepened in a straight line to the level of the prostatic capsule, which is recognized by its smooth appearance. In this case, the bladder neck is incised initially on the right. The line of incision is along the anatomical groove between median and lateral lobes.
So these bladder neck incisions, like they said, are done at 5 o'clock and 7 o'clock.
As the capsule is approached, the adenoma splits apart widely. Bleeding vessels can be coagulated by defocusing the laser beam. This is best achieved by standing back from the tissue and advancing slowly until blanching occurs. At the level of the verumontamen, the bladder neck incisions are curved laterally and upwards following the contour of the prostatic apices. The surgical plane between capsule and adenoma is easiest to find, just lateral to the veru. Time taken to ensure clear demarcation of the bladder neck incisions is well spent, as these, along with a later incision at 12 o'clock, are important landmarks for the enucleation. Once the bladder neck incisions are completed at 5 and 7 o'clock, the median lobe can be enucleated. The median lobe is incised transversely from one bladder neck incision to the other, beginning just above the verumontamen. The entire lobe is then peeled from the capsule until only a narrow attachment at the bladder neck remains. Once this attachment is divided, the lobe floats up into the bladder. In this case, there is a relatively long distance between bladder neck incisions. A transverse incision is made to the level of the capsule to connect the two incisions. The beak of the scope is then gently nudged under the free edge of the median lobe and lifted up to create traction that allows the laser energy to peel the lobe from the capsule, be pushed up into the bladder.
So the median lobe is now removed.
Any remaining bladder neck attachments are divided and the lobe detached completely. Hemostasis of the floor of the prostate cavity is secured. The next step is enucleation of the lateral lobes of the prostate. This is achieved by approaching the lateral lobe initially from below. The lateral lobe is then approached from above. Once these two planes are connected, the lateral lobe can be peeled forwards into the bladder and detached. On the left, the 5 o'clock incision is extended laterally and upwards in a curvilinear line that follows the surgical plane between adenoma and capsule. As with the median lobe, once the correct plane is entered, much of the enucleation can be achieved by applying gentle pressure with the beak of the scope. The laser, following closely behind, obtains excellent hemostasis. A third bladder neck incision is created at 12 o'clock from the level of the verumontamen to the bladder neck. In this case, a strand of tissue remained distally, and this was divided to allow detachment of the lateral lobe.
The procedure is then repeated for the right side.
The final step is morcellation of the detached. The final step is morcellation of the detached prostate lobes from the bladder. This is a simple and safe procedure as long as a few basic principles are adhered to. Firstly, vision must be clear at all times. Secondly, the window in the morcellator blades must be kept in contact with prostate tissue whilst activated. And thirdly, the bladder must be kept fully hydrodistended whilst morcellating. Morcellation rates averaging 5.
And that's the basic principles on a whole lip procedure in terms of a video. So the main complications of whole lip is bladder injury, and this is usually because of incorrect techniques when doing the morcellation step of the procedure. Sometimes one can also incompletely evacuate the adenoma. That's usually due to technical difficulties. You can have injuries to the UOs, which is quite rare. You can have perforation of the capsule of the prostate, which is also not very common, but can be treated easily with a transurethral catheter. Bleeding. Patients also have post-op storage symptoms, urinary incontinence, which is a transient incontinence. Patients can also develop bladder neck contractures, urinary strictures, and retrograde ejaculation. So in terms of analyzing some of the data for whole lip, I came across this article, which was basically a systemic review, a systemic review and meta-analysis of the efficacy and safety of whole lip and transurethral resection of the prostate. So basically, with the this review, they performed an updated meta-analysis in comparing efficiency of whole lip and TURP. These articles were articles that the articles reviewed were reviewed between 1996 and 2008 and 2018, sorry. And basically they found that with operation time, whole lip was a bit longer than TURBT, TURP. The blood loss was less with whole lip. Hospital stay was shorter with whole lip. Catheterization time was shorter with whole lip. Bladder irrigation time was shorter with whole lip. The amount of gland resection was the same, though the Qmax at 12 months and 24 was more superior with whole lip. The residual volume was more improved with HOLOP at 6 months and 12 months. IPSS score was more superior at 12 months with HOLOP. There was no significant difference in the patient's quality of life. And the only really significant adverse effect for HOLOP was the dysuria that they found from the systemic review. Basically, they concluded that with small to medium-sized prostate, it looks like HOLOP gives better long-term results, but further randomization clinical studies would also help in terms of getting further knowledge about this. And the EAU does recommend the use of HOLOP for moderate to severe LUTs for patients with BPE. As an alternative to transurethral resection of the prostate or open prostatectomy. The evidence that they found according to HOLOPs mimics basically that article that I went through, that it demonstrates high hemostasis and intra-op safety compared to transurethral resection. The next intervention I wanted to speak about was prostatic urethral lift, which has been marketed as UroLift. Basically, this is the insertion of permanent implants that retract the obstructive lateral lobes, creating a new anterior channel through the prostate without obliterating the tissue. The implant is a monofiber suture with 2 stainless steel tabs on each end. There's a handheld delivery device which delivers the implants through a cystoscopy. The patients that have been recommended for UroLift are patients only with lateral lobe obstructions, not median lobes, prostate smaller than 80 grams, and patients who desire fertility. So the procedure can be done in an office setting and under local anesthetics, but under local anesthetics through a rigid scope. Have another video here of the UroLift.
And as we go through the prostatic urethra, here we are inside bladder. You see a little bit of trabeculation, nothing bad. Unfortunately, I have some bubbles at the lens. I removed the lens and the obturator from the patient, leaving the sheath in place. And now my assistant is helping me load the UroLift device onto the lens. And here we are inside the patient's bladder. Now, this is the first implant, air bubbles right there. I'm slowly, again, not full blast on the irrigation, and you'll see me focus the camera right there so you get the most crispy image. I placed the first implant at the patient's left side near the bladder neck, about 1.5 centimeters distal to the bladder neck. I find the right reflection and I deployed the implant. So that's implant number 1 out of 4 from this procedure. My assistant then helps me unload the used UroLift device, and then helps me load the new one like that. I reintroduce the device into the patient. Now, when I put in the device, I do not push it all the way in against the mucosa. I don't want to damage the bladder mucosa. Instead, I withdraw the sheath a little bit when I put the device in. Now I'm going to put the device in the patient's right bladder neck. I compress laterally, say anterior. I make sure the suture is perpendicular, and then I deploy the implant and I cut the suture. Again, the bladder is not over distended, irrigation.
So 4 implants are inserted on the left and the right, each implant, 2 at the bladder neck and 2 proximal to the veru.
Degree lateral compression, make sure the suture is straight, cut, deploy. And here with the irrigation off, you can see a nice big open anterior channel after the deploy.
So that anterior channel is created after inserting, like I said, 4 implants into the prostate. So the advantages of UroLift is that there's low rates of local symptoms because you don't actually go through the mucosa of the urethra. The mucosa remains intact. So therefore, there's less irritation in terms of on the mucosa, less bladder neck contractures, less voiding symptoms, less storage symptoms for the patients. There's also minimal impact to sexual function because the implants are inserted at anterolaterally. They do not injure neurovascular bundle, so therefore there's decreased ejaculatory dysfunction. ED, and ejaculation itself is preserved because the bladder neck is preserved. Some adverse effects is that you can get mild symptoms, which are very transient in terms of irritative symptoms. The urolift does have a failure rate of about 10%, and most of the time is related to poor placement. So patients who are young and decide to get urolift must be informed that later on they might need a second procedure. And obviously it's not indicated for patients who have a median lobe. So this article basically was to compare the urolift with a TURP with regards to symptoms, recovery, experience of the patient's sexual function, continence, quality of life, sleep, and patient perception. This was a prospective randomized control non-blinding study with 80 patients in 10 different centers in Europe. So there could have been bias in the study, but they did find that with the IPSS score, TURP was IPSS score. The TURP had a higher score improvement. QMAX TURP had a higher score improvement. Quality of recovery, the urethral lift had a better quality of recovery, quality of life and erectile function was the same for both procedures, but ejaculatory function was more superior with a urolift. Patients' symptoms were the same in terms of improvement for both procedures. Continence, nocturia, quality of sleep, and other and reduction in additional treatment favored the urolift. Basically, these findings are also echoed by the EAU, basically saying that the urolift has got improved QMAX and quality of life. Although it's although it's inferior to TURP, they do recommend that you can offer this procedure to patients with a prostate of less than 7 grams and no middle lobe. The next procedure I wanted to talk about was convection radiofrequency water vapor thermal treatment, which has been marketed as RESM. So RESM basically utilizes radiofrequency to power to generate thermal energy in the form of water vapor, in other words, steam. So the steam is injected transurethral into the transitional zones of the prostate at 103 degrees for 9 seconds. It's injected at a pressure that is slightly above interstitial pressure, causing dispersion of the steam throughout the cells via convection currents. So when the water vapor comes into contact with the tissue, it condenses, and the steam then forms liquid. This condensation causes a high energy surge of 540 calories, which causes cell death, cell necrosis, which is in a form of a spherical lesion. So patients who can be considered for resume patients with a prostate size of 30 to 80 grams, patients who are high risk for anesthetic procedures in terms of general anesthetics, patients who would still require fertility. So the procedure can be done in an outpatient setting with oral or conscious sedation or even a prostate block. The system is composed of a generator, a handheld delivery system, which has a needle, 18-gauge needle, which goes into the tissue and is retractable. Then I just wanted to share the video with you.
The following is an example of a resumed procedure in a 51-gram prostate. After priming, the delivery device is placed into the urethra and advanced to the bladder. Once the bladder is entered, it is recommended to measure from the bladder neck to the viru to determine the length of the prostatic urethra. One field of view represents 0.5 centimeters, and each treatment should begin 1 centimeter from the bladder neck, moving toward the viru in 1 centimeter increments. Once measurement of the prostatic urethra is complete, return to the bladder neck and begin treatment on one side of the prostate. It is Dr. Cantrill's practice to start on the left side of the prostate, but either side is acceptable. Once beginning treatment, continue ipsilaterally to the viru, targeting the bulk of the adenoma. It is recommended to allow the needle to remain deployed for 1 to 2 seconds after completion of the 9-second treatment to ensure all phase change of water vapor is completed. If a vapor leak is detected, noted by rapid release of bubbles, moving the delivery device gently in the direction of the leak will help to seal the leak and continue with the therapy. With large vapor leaks, greater than 3 seconds of the therapy, it is recommended to retreat the area with an additional treatment. Taller prostatic urethra may require stacked therapy to create a continuous channel, or a Z-like pattern may be used to follow the natural course of the urethra with an elevated central zone. When intraprostatic protrusion is noted of the lateral lobes, it is recommended to treat measuring from the tip of the intravesical protrusion, not the bladder neck, to ensure full treatment of the obstructing tissue. After completion of the lateral lobe treatments, the central zone or median lobe tissue may be treated. It is recommended to treat central elevation when there is difficulty entering the bladder or the prostatic urethral angle exceeds 40 degrees. This is done by moving the delivery device to the right or left of the field and entering the tissue at a 45-degree angle, aiming for the middle of the prostatic tissue. The central zone typically only requires 1 treatment. When a median lobe is present, the same procedure is done, but should be completed on either side of the median lobe.
And that's basically the resume procedure. The advantages of the resume is that you can target lateral and median lobes. You preserve sexual function. There's a low retreatment rate. It's an outpatient office procedure with a minimal learning curve for the surgeon. And once again, patients can still experience mild transient irritative symptoms post-op. So in terms of looking at some of the data for the resume, this was an article basically that the objectives was to report on the effectiveness, safety, and 4-year outcomes of a randomized controlled trial of resume water vapor thermal therapy for severe LUTs. So basically, with this study, it was a prospective, multi-centered, double-blinded trial. So with less bias, or less chances of bias. Basically, patients were randomized to a control and an intervention, and the patients in the control just got a simulation of an operation where they were in theater. There was some noises that occurred, and the intervention patients received the resume treatment. In terms of their results, this graph here at A basically shows the IPS score of the patients. They found that the basically resume gave a significant decrease in the IPS score, and that decrease was durable for quite a long time. And in the graph at B shows the Qmax. And Qmax from baseline to 1 year improved from 10 to 14.5 and remained improved. And graph C basically was the patient's quality of life. They found the quality of life score obviously also decreased and remained stable for 4 years. And D was the BPH impact score, which also improved and also stayed and was also durable. So when assessing the adverse effects, they found that intra-op there was not much complications from the resume, but patients did experience some dysuria afterwards, some frequency and urinary retention and urgency. Resume did unfortunately also have quite a bit of a failure rate, where 5.2% of the patients were then treated with beta blockers medical treatment, and 9.6% of the patient had to have a second operation. So resume is still a procedure that's under investigation by the EUA. Basically, they say that randomized controlled trials against the reference technique need to confirm the first promising clinical trial results. So the next intervention is aqua ablation, which has been marketed as aqua beam. So aqua ablation uses hydrodissection to obliterate the prostate tissue. There's no thermal energy, there's no laser. It's just high velocity saline jets streams that break down the tissue. It's image guided in terms of a transrectal ultrasound probe, which shows real-time treatment. We use saline stream to ablate the prostate tissue. It spares collagen structures like blood vessels and the actual capsule of the prostate. Patients who can be deemed suitable for aqua ablation, patients who do not have any contraindications for regional or general anesthetics, patients with a prostate size of 30 to 80 grams, once again, patients who require fertility. So the system consists of a console or a pump with a robotically controlled arm. And the arm is attached to a 20-French handpiece. There's also ultrasound with a screen. It's done under regional or general anesthetic, as I've said. And this was just a short video, once again, just to see the procedure here. So like on the video, you see that you firstly insert the ultrasound probe, have a look at the prostate, and then you insert the handpiece, which is integrated with the cystoscopy. And then you lock the handpiece in place once you've found the prostate, under guidance from the ultrasound with a bed rail mounted articulate arm. You then look at the ultrasound, and then you first choose the angle of resection. Using different views, you also go into a sagittal view to confirm that the treatment zone, to the shape of the adenoma. That's the sagittal view there. And once you've confirmed the treatment zone, you adjust the treatment zone to make sure that it does not include your bladder neck or your external urethrosphincter. Once adjusted and everything is ready to go and you're happy with your treatment zone, the robot is then starts the resection. This is initiated by the surgeon himself, who has a foot pedal, presses on the foot pedal, which initiates the treatment. Basically, the treatment starts proximally, goes down distally, with the water jets moving in a sweeping fashion through the prostate. Changes in the water jet velocity can regulate the depth of the ablation of the targeted tissue, and the treatment is monitored with an ultrasound or cystoscopy during the procedure itself. So once the procedure is done, hemostasis can be gained by can be achieved with using a resectoscope, or by putting a transurethral catheter under tension in the prostatic fossa. So the advantages of the echoablation is that the application of the robots, it allows you to do precise ablations and reduces the learning curve. There's no thermal energy, there's no laser energy, therefore there's no actual injury to the bladder neck, the nerve tissue, and the external sphincter, therefore minimizing the impact of developing symptoms such as incontinence, ejaculation issues, and erectile issues. But there is still a problem with the bleeding as no proper management for the post-op bleeding has been described yet. This was just a trial, a study that was done, water study, which stood for water jet ablation therapy for endoscopic resection of the prostate tissue. Basically, with this study, it was a double-blinded study, multi-centered randomized control trial, and 181 patients were put in this trial, basically to compare the safety and efficacy of echoablation and a transurethral resection of the prostate. Basically, they found in this trial that all these parameters improved equally for both echoablation and transurethral resection. But they found that echoablation did show a slight superiority compared to transurethral resection. So the major things here you can highlight is that the resection time is 4 minutes compared to 27 minutes for transurethral resection. The only thing, once again, was the bleeding for echoablation. They found that adverse effects in echoablations were lower, grade group 1 and 2. And ejaculation and erectile function remains stable in the patients with echoablation. So basically, just like the EAU findings, they found that echoablation is as effective as transurethral resection, but they still don't recommend echoablation as standard procedure, but rather they recommend that you inform patients of the risk of bleeding and that there's a lack of long-term follow-up data with echoablation. So more data is needed for this intervention. So the next thing procedure I like to talk about is minimally invasive simple prostatectomies. So with the minimal invasive operations, we know them quite a bit, laparoscopic prostatectomy and robot-assisted. Laparoscopic first described in 2002 and robots assisted in 2008. But there's a lack of randomized control trials for these interventions in terms of simple prostatectomies. Multiple techniques have been described to do them. Based on transcapsular and transvesical techniques of open prostatectomy. Usually laparoscopic is done extraperitoneal and robotic is done transperitoneal. So patients who qualify for a simple prostatectomy are patients who have indications for surgery, as I've mentioned them before, but who also have a bit of a larger prostate, larger than 75 grams, patients with concomitant bladder conditions such as diverticulum and calculi. So a patient who's going to also require a diverticulotomy because of this procedure can be done at the same time during the prostatectomy, and removal of calculi that can also be done at the same time. A patient who has any orthopedic conditions that prevents them from positioning during endoscopic procedures, patients with recurrent or complex urethral conditions such as strictures, patients who've had previous hypospadia repair, just to avoid urethral trauma associated with endoscopic procedures. Patients who have associated inguinal hernias, basically you can just do the hernia repair and the simple prostatectomy at the same time. And obviously your patient has to be fit for general anesthetics. The most important thing about minimal invasive techniques is minimal invasive simple prostatectomy is the blood loss. There's minimal bleeding as compared to open prostatectomy. And the symptom improvement score and quality and Qmax was found to be more superior out of all the interventions for prostates. So most of the disadvantage is that there's quite a high learning curve, steep learning curve. So in order for you to be able to give patients good results, you need to have done quite a number of these procedures, and these can only be achieved in high volume centers. The operation time is long, and the cost of the actual equipment in terms of by procuring a robot is one of the big disadvantages. And then you have procedure-related complications such as urinary extravasation, incontinence, urge incontinence, stress incontinence, total incontinence. And then you find that these patients will have to have other procedures such as artificial sphincters to manage the incontinence, sexual dysfunction, bladder neck contractures, and non-procedure related complications related to the anesthetics and being bedbound, such as DVTs, PEs. So this article, basically outcomes of minimal invasive simple prostatectomy, they wanted to assess the outcomes of minimally invasive simple prostatectomy in patients with large prostates and compare them to open prostatectomy. So in terms of the efficacy of minimal invasive prostatectomy, they found that post-op and pre-op findings was in terms of Qmax, Qmax increased quite a bit with minimal invasive, and they found that the IPSS score also improved. And in comparing it to open prostatectomy, the IPSS score was similar with both groups. The Qmax was similar with both groups. The major advantages was that simple prostatectomy had shorter hospitalization stay, shorter catheterization time, less bleeding. It's just that the operation time was also a bit longer. The conclusion basically was that a minimal invasive simple prostatectomy is effective and safe treatment option. The main advantage is the less blood loss, catheter length was and hospital stay was reduced. Once again, the EAU has not put in minimally invasive simple prostatectomy as part of their recommendations. It's still under investigation, and they feel that more randomized controlled trials are needed. The last intervention I wanted to speak about was prosthetic artery embolization, which we spoke about quite immensely during this morning. So I'm just gonna go through it quite fast. The main things that I found was that the advantages is that there's no destruction of tissue, there's decreased rates of, so therefore there's decreased rates of complication. The need for hospital admission is decreased. Patients have quick recovery time and decreased blood loss. But there's still quite a bit of evidence that post-embolization syndrome does occur, where patients have pain and a fever, local side effects from catheterization of the vessels, pseudoaneurysms and bleeding. Patients with contrast allergies cannot have this procedure. There's quite a bit of exposure with radiation, and it's technically challenging. So you have to have an experienced interventional radiologist who works together with a urologist and in a high expert center. So this was a study, the UK ROPE study, which was done in conjunction with urologists, interventional radiologists, and the NICE organization to assess the efficacy of prosthetic artery embolization and comparing it to TRP. Basically, they found that there was improvements in both the prosthetic artery embolization and TRP, but TRP still was more superior than prosthetic artery embolization. As you can see here, the IPSS score was significantly higher, quality of life was almost similar. Sexual function there was no difference. Qmax higher in transurethral resection. Prostate volume, there was nothing to compare with in terms of TURP from the data that they collected. The residual volume was also decreased quite significantly more in TRP. And they found that in terms of complications, the most common complication they found was hematuria, which unfortunately was more higher in transurethral resection. And in terms of failure rates, they found that prosthetic artery embolization has a total failure rate of 20% compared to 5.6% of TRP. So once again, prosthetic artery embolization not recommended by the AUA, but still remains under investigation. The EAU recommends that this can can be done where there's expert interventional radiologists who's trained in the procedure, and who can identify patients properly suitable for the procedure. This was just a summary of some of the evidence that I found. I see we ran out of time. I just wanted, I would have gone into a bit more detail about this, but basically, just to summarize that each intervention has got its own advantages and disadvantages, but the most important is to have good patient selection, know what the surgeon's capabilities, and although some of the interventions are still under investigation, there are promising results, and hopefully minimal invasive interventions for BPE will be our way forward. Thank you.
Thank you, Nkanyesi. Hope you can hear me okay. Just to congratulate you on putting together an absolutely superb talk. I thought the combination of the videos plus reflecting on the literature was very well received. Thank you. I'm just looking around if there are any questions. I think that you've introduced us to a lot of new technologies. They're clearly competing for the same space. That last slide of yours was very useful to show that certain features may make them applicable to certain clinical situations more than other techniques. What's your sense of the literature in Nkanyesi? Which do you think of those is going to win out amongst these four techniques?
Prof, to take you back to the slide again, I think, like I said, the most important thing is your patient selection and the prostate size and your abilities as a surgeon, and what you want to achieve. In terms of if in my hands, I would say for a smaller prostate, I would rather suggest something like a prosthetic urethral lift. It's got a very minimal learning curve. It can be done as an outpatient. Patient's sexual function is preserved, and patients have quite a bit of symptom relief. And if later on the patient needs a second procedure, then you can discuss that with the patient. But usually reoperation rates usually occur after 3 years. So at that point, then maybe you could consider something else. For the larger prostates, I would prefer laser techniques such as HOLIP. The simple prostatectomy still, to me, has got quite a steep learning curve, and having also a cost in terms of acquiring a robot would be a disadvantage, especially in our setting in Africa. I think those resources could be channeled elsewhere, and for the larger prostates, maybe focus on trying to hone on our HOLIP skills, which there have been studies showing that prostates up to 120 grams can actually be done via HOLIP safely with good results.
Thank you, Nkanyesi. Just seeing if there are any other comments from or questions on the chat. Don't think I see any there. So I think, Nkanyesi, thank you very much. I think it just remains for us to wrap things up, and we look forward to seeing everybody next week. Thank you.
Thank you, Prof. Thank you.